Okay guys, I'm going to be talking to you about a case that I had a couple weeks ago that could potentially be a good learning point or teaching point for future cases and other providers. The case was for a 56-year-old male that presented for a right total knee arthroplasty. Didn't have any previous drug allergies that were known. Previous surgeries included a knee scope for both his left and right knees, tonsils and adenoids removed, and had had an ORIF of a left wrist 3 years ago. He had no previous complications with surgeries. His current medical problems were he had smoked half a pack a day for 10 plus years, drank 1 to 2 beers weekly, has no history of drug use, does have high blood pressure, seasonal asthma, and osteoarthritis in his main joints, including his knees and hips, which is why he was here today. He had no previous history of an MI, chest pain, cardiac history at all, no strokes, and he did have some acid reflux that he kept controlled. So for this, one thing to consider is prolonged smoking can lead to chronic obstructive pulmonary disease, which may lead to increased peak airway pressures, CO2 retention, increased airway secretions. So some things to change for this, you can change your IE ratio to allow longer expired times, which kind of helps prevent some of the CO2 trapping. Maybe add a little bit of PEEP for alveolar recruitment. So some of the medications that he was taking were lisinopril, Singulair, PRN, and the Nexium for his acid reflux. So anesthetic considerations for these would, like, for example, the lisinopril is, according to Flood, ACE inhibitors such as lisinopril, if taken up to the time of surgery, can lead to severe hypotension during the induction and maintenance phase of surgery. His admitting vital signs were 138 over 84, heart rate 78, respirators were 18, oxygen on room air was 98%. His temperature was 98.2. He weighed 109 kilograms. His pre-op EKG that morning showed a normal sinus rate at 72 beats per minute with possible mild left ventricular hypertrophy. Chest x-rays showed no cardiomegaly, granulomas, infiltrations, or acute disease. His current labs were an H&H of 12.9 and 37.1, white blood cell count of 6.2, platelets of 168, sodium 141, potassium 3.9, BUN 16, and creatinine of 0.89. Calculated fluid deficit for basically the last 8 hours since his first case of the day to be approximately 1,200 milliliters. His allowable blood loss would be around 1,500 mils to give a change crit down to 30. Estimated blood volume of just over 8,000 milliliters, and a fluid of choice for this patient was LR. The patient was rolled to the OR suite and positioned on the bed. Standard ASA monitors were applied, including blood pressure, pulse ox, and EKG leads. Pre-oxygenation with 100% O2 during spontaneous breathing while you're hooking up the monitors and all that kind of stuff. 100 mics of fentanyl were given. A smooth, rapid sequence induction with cricoid pressure with 200 milligrams of propofol and 100 milligrams of succinylcholine were used due to the patient's acid reflux. Even though it was controlled, kind of better to be safe than sorry. Tape the eyes using a MAC 3 blade. Direct laryngoscopy was performed ×1. Size 8 endotracheal tube was visualized passing through the cords. Endotracheal tube cuff was inflated to minimal occlusive pressure. End-tidal CO2 was confirmed with 4 breaths and fog in the tube. Bilateral breath sounds were equal. Tube was taped in place at 23 centimeters at the lips. Lips and teeth remain in pre-op condition. Sevoflurane was the gas of choice and titrated to an end tidal of 2.2%. Again, this was kind of titrated throughout the case just to keep the patient, the vital signs stable, as well as keeping them comfortable for the procedure. So throughout the procedure, no problems and no real significant problems came up. Again, gas was titrated for stable blood pressure, heart rate, and sedation. The patient's vital signs remained stable throughout. Towards the end of the case, zofran was administered to help with post-op nausea and vomiting prevention. Studies have shown that given zofran towards the end of the case, especially for longer cases, the prophylaxis for post-op nausea and vomiting has a higher success rate. So that's why it was given at the end of the case. Zofran, which is known to, does have the potential for having a prolonged QT if administered too fast, and it can also give the patient a headache. The Zofran was administered via IV push. Normally it says to give the Zofran over 2 to 5 minutes. I know most of the time it's given a little bit faster than that, and in this case it was given faster than that, but it was not just a slam the syringe IV push. Shortly after the administration, the patient's heart rate dropped from the low 60s, which it had been running at, to the low 40s. So it turned around to grab the glycopyrrolate, and the heart rate kind of continued to drop steadily. By the time that the Robenal was drawn up and given, the heart rate had dropped down to kind of the low 30s. 0.4 milligrams of Robenal were given. The heart rate began to increase to the low 40s. Then the blood pressure that was taken after the heart rate had dropped was lower. So normally, you don't treat bradycardia unless it's a symptomatic bradycardia, meaning you have a lower blood pressure, or if the patient's awake having other notable changes. So in this case, when the heart rate, again, had already been treated a little bit, but the blood pressure had still gone down, so 10 milligrams of ephedrine were given. The heart rate then stabilized back in the 60s with a systolic pressure in the 120s, which for this patient, if the pre-op pressure was approximately 140, you want to keep it within 20% of your beginning pressure. So the patient remained stable throughout the emergence and post-operative phase. The patient was extubated awake due to having acid reflux, and which leads them to potential aspiration risk. So you want them to wake up so that they can protect their airway, which in this case was more important to me than maybe having a reactive airway due to their asthma, which for him was a little bit more seasonal allergies. So again, I did know that Zofran had the potential to have a prolonged QT and a headache if it was given too fast, but I did not know anything about the bradycardia, which in a way makes sense. But so I went home, did a little bit of research, and according to Vargo and a couple sources, it does say that Zofran can cause symptomatic bradycardia. I also found several articles online that saying, although it is rare, Zofran has been shown to cause severe bradycardia in some patients. So just a kind of a heads up and something to be aware of, because obviously it was something that I wasn't. So it's always nice to, unfortunately, sometimes we kind of learn from our mistakes. So patient, like I said, did well throughout recovery. No noted EKG changes or residual deficits or anything like that from the incident. So for this patient, other anesthetic considerations that could have been used, many times for total knees and joints, especially on the lower extremity, on the lower extremities, patients can benefit from a spinal, which the spinals usually don't last as long as doing doing their axial blockade, such as a spinal does not last quite as long as doing a peripheral block. So this patient could have benefited from a spinal, or could have benefited from doing the 3-in-1 block, the femoral, the obturator and popliteal nerve is also a common combination. By doing this also decreases the amount of narcotics that are given to the patient. You can run them at a lower MAC value because you're not going to get much stimulation from the procedure, which also sometimes may affect you, especially in this case for this patient. If they had taken lisinopril up to 24 hours, up to the time of the procedure, which this patient had, the surgical stimulation does sometimes help to try to get your blood pressure back up if you've had hypotension due to the induction phase. And not only do peripheral nerve blocks decrease the narcotics and the volatiles that are used, but they hang around longer than a neuraxial block. So like I said, this is just a specific case that I dealt with, and it's one of those things where, although it is rare, it does actually happen. So just something to kind of keep an eye out for. So this concludes the case study for this patient. Thanks.